In January 2026, the FDA quietly removed the suicidal behavior warning from Wegovy, Saxenda, and Zepbound after pooling 91 placebo-controlled trials over 107,000 patients. It did not trend on social media. It should have. In this video, I'm going to walk you through exactly what the evidence shows on GLP-1 drugs and mental health, depression, anxiety, suicide, substance use, eating behavior, and cognition. The good signals, the unsettled questions, and the screening every responsible prescriber should be doing. GLP-1 and mental health, a physician's evidence review. Please stay with me as we review the literature. This is Dr. James Ries from 20 Mile Medical, a board-certified telemedicine practice focused on evidence-based metabolic medicine, longevity protocols, and careful prescribing. My goal here is to give you the same quality of information your doctor should be giving you, with citations, clinical context, and honest uncertainty where it exists. Not pharmaceutical marketing, not social media panic, just the literature studied carefully. Let me lay out the evidence the way a clinician would. Start with the strongest designs. The FDA itself pooled 91 placebo-controlled randomized trials across every GLP-1 development program, over 107,000 patients. No increased risk of suicidal ideation, suicidal behavior, anxiety, depression, irritability, or psychosis. That is why the warning came off the label. The FDA Sentinel system reviewed over 1.1 million GLP-1 starters. Adjusted hazard ratio for intentional self-harm showed no increased risk. JAMA Psychiatry pooled 27 randomized control trials. Rate ratio 0.76, no increased risk. The 2026 Lancet Psychiatry registry found 42% lower psychiatric hospitalization, 44% lower depression incidence, 38% lower anxiety on treatment. The Nature Medicine study found a hazard ratio of 0.27 for new suicidal ideation in obesity. Not increased risk, but lower risk. This is not one paper. This is a stack of independent designs converging on the same answer. The signal is not just no harm. It is a small to moderate favorable signal across 5 domains. Here is what the evidence shows. Depression and anxiety. In the STEP semaglutide trials, the PHQ-9 difference versus placebo showed severe depression categories were reduced by 37%. Suicidal ideation and self-harm. No increased risk in any high-quality dataset. The Nature Medicine cohort shows protective signals out to 3 years. Alcohol and substance use. This one is striking. The All of Us nested case control showed 68 to 75% reduced odds of new substance use disorders. The Cerner cohort showed roughly 50% fewer alcohol intoxication events and 40% fewer opioid overdoses on GLP-1s. The mechanism makes sense. GLP-1 receptors dampen dopamine release in the nucleus accumbens, blunting the reward signal for alcohol, drugs, and hyperpalatable food. The only completed alcohol use disorder randomized control trial was negative on its primary endpoint. So this is not approved for addiction yet, but the observational and mechanistic case is real. Patients describe food noise, intrusive thoughts about food between meals, dropping or disappearing. Multiple studies of binge eating disorders show reduced binge frequency and improved BES scores. Cognition and neurodegeneration. Observational data suggest reduced incidence of Alzheimer's, Lewy body, and vascular dementia. The Evoke Plus oral semaglutide Alzheimer's trial reads out in the next 12 to 24 months. Reviewing the 5 domains: mood, suicidality, substance use, eating behavior, and cognition. Now the part the headline skipped. The STEP, SUSTAIN, and SCALE programs, the trials that generated almost all the safety data we have, excluded patients. These were patients with active severe depression, active suicidal ideation, schizophrenia, severe bipolar disorder, and active eating disorders. That is standard practice in pharma trials. It is also the boundary of our knowledge. So when I say GLP-1s look psychiatrically safe at the population level, I mean exactly that. Average obese or type 2 diabetic patients, safe. A patient with active suicidal ideation and active eating disorder, untreated psychosis, we do not have great data. Different conversation, different workflow. Study authors themselves recommend psychiatric history assessment before prescribing, which is exactly the point. The lesson is not do not use these drugs. The lesson is have a real mental health pathway in place before something surfaces, not after. That is why we built one. Here is what most patients do not know. The biggest difference between telehealth platforms is not the molecule, it's what happens if something comes up. At 20 Mile Medical, every GLP-1 evaluation includes a brief intake screen for red flags, personal psychiatric history, suicidal thoughts, active eating disorder symptoms, untreated psychiatric illness. Anything that says this is the wrong starting point or we need a different plan first. That is the gate. But the real difference is what sits behind the gate. We run a mental health subscription for $69 a month, staffed by the full 20-mile medical provider team under my supervision. If anything surfaces during GLP-1 treatment, the patient is already inside a continuous supportive care relationship. The way you address this is not by trying to do every validated psychiatric intake. It is by being available continuously if something comes up. Rapid weight loss can trigger body image issues and disordered eating relapse, especially in patients with prior history. We watch for that. When you work with a board-certified physician who built a real mental health pathway for the people he treats, that is what responsible telemedicine looks like. My honest perspective after working through this literature is that the question is, at the population level, settled. The FDA, the Sentinel system, JAMA Psychiatry, Lancet Psychiatry, and Nature Medicine all agree. These datasets suggest patients are getting modestly better on mood, anxiety, substance use, and eating behavior. The mechanism is biologically sound. The convergence across designs is unusual and reassuring. The first phase 2 trial of semaglutide in major depressive disorder with obesity is enrolling. The first phase 2 trials in alcohol use disorder and opioid use disorder are running. The Alzheimer's phase 3 readouts are imminent. 3 to 5 readouts will reshape this field over the next 2 years. GLP-1s are not psychiatrically dangerous. The strongest available evidence says that clearly. They may, on average, modestly help mood, anxiety, substance craving, and eating behavior. The reason a real mental health pathway still matters is that the trials excluded the highest-risk patients, and good telemedicine fills that gap by being available when something comes up. 20-Mile Medical offers telemedicine consultations, board-certified evaluation, evidence-based protocols. Our mental health subscription at $69 a month runs alongside, staffed by my provider team under my supervision. Subscribe for more content like this. Drop your questions in the comments. I am Dr. James Ries. I will see you in the next one. This video is for educational purposes only and does not constitute medical advice. Please consult your physician.